Well, once again, thank you all for joining this Congress. We feel so privileged having you. We heard a lot in the last few minutes or so about the progress in myeloma survival, all the advances, the achievements. We heard a lot about these novel, wonderful drugs, which are really making a difference in the life of our patient. Also, we can debate about their costs, their development, their production. But I think we should bear in mind that behind all of these advances, there are men and women working very hard to bring this into the field, to bring it into the bed to our patient, these drugs, these advances. And since the beginning, when we started thinking about the organization of the second edition of the Congress, all three of us immediately agreed that it is our responsibility, our duty also to acknowledge the hard work of these people, these investigators, physicians, doctors, who are dedicating their career, their time. They are sacrificing the time of their families, their weekends. You know, they will be here this weekend. You can be with your wife, your children, but they are dedicating their time, their energy, sometimes a lot of resources and sacrifices towards improving this. And this was the background why we created the Achievements Awards. And actually it proved extremely successful because we received more, between 12 or 15 applications who fulfilled the criteria. And we wanted to be very transparent, very objective. The criteria for the awards were published. There was a public call, and there was an quantitative evaluation on criteria. We ticked boxes, we added impact factors, and that was done under independent supervision. The deadlines were respected. The application received after the deadlines were simply refused, and we apologized. And after doing all of this evaluation, we had actually ended regarding the clinical award actually with two candidates who won, I would say, because they ticked the same boxes and merits. And this is why it is my pleasure to introduce. So then we had to decide how we're going to do the order. And I thought it should be the alphabetical order. That would put us on the safe side. So this is why it's my great pleasure on behalf of my colleagues to present the Multiple Myeloma Achievement Award as part of this COMy, and we commit that these awards will continue permanently. And by the way, the amount of this award for each investigator is 10,000 euro, and this is not sponsored by any company. This is the resources of the meeting who are paying for these awards to support these investigators, their research, their group, their teams, and so on. So it's my great pleasure and honor to introduce the first winner, Professor Antonio Palumbo from the University of Torino in Italy. As a matter of fact, I will not read his CV because he will give us a presentation about his work and his achievement and how this has advanced the field of multiple myeloma. So maybe, Antonio, you can give your presentation and then we take the photos after.
Well, thank you very much. I'm very honored of this award, and I have it in this last slide, but I want to start in this way. This is probably not so. There are so many other people that deserve it much more than me, and beside the one person, what I want to make is that there are the patient, the nurses, the physician, the study coordinator. There are so many other people that really make this happen. So I'll take the credit, but I think all the others have probably more credit than I have. Having said that, I don't want to take too much time. Has been said clearly, and I want to follow also what Jean-Luc has been said until now. We have improving the outcome of myeloma very much, and we have much more opportunities. But to some extent, what is important, this is a slide that probably many of you know, what is important is to be clearly more effective and to understand that to some extent what is important today in myeloma is to definitely have this type of quality, a major advantage in the front line. Do avoid this type of treatment, because I would like to make two very simple concepts. We are very much concerned on high-risk patient. We should realize that the good prognosis patient is here, the high-risk patient is here. So basically, the good risk is at the beginning of the disease, and then every single patient becomes a high-risk patient. So it's very important to get concentrated in early phases of diseases, and probably to be much more palliative than we are in later stage. But there is another consideration I would like to give from an epidemiological point of view that is not very well known. If you have 100 patients in first line, you only have 60 patients in second line. You only have 35 patients in third line, and you only have 20 patients in fourth line and 10 patients in fifth line. This is telling you a basic heterogeneity of the disease. These are, of course, the one with a major genomic stability, and the disease is not getting so aggressive. But the point is, if I have an option, the cards are here. Here is probably, to some extent, too late, and we lose too many patients. Another issue is complete response. I completely agree, and I'm following what Jean-Luc was saying. Now we have a continuous therapy, is getting there. We should probably develop a better way of deliver continuous therapy, probably a stop and go. We have to work on this. But today, another issue I would like to leave is the concept of complete response is not so clear in myeloma. You can see here from an MRD point of view, we are not really able to see the eradication of the disease because we only see the surface of the eradication. The cure is much more below what we can see. And think about the serum tools. The immunofixation is only going to 10 to -2. Even next generation sequence is -6, the cure is much below. But there is another issue that is coming, and actually is coming from the French cooperative group, that myeloma is much more a lymphoma pattern than not leukemia pattern, in the sense that the localization outside the typical bone marrow, when we do the test that we see with a CPET, is extremely important. You can see here all patients are MRD negative, and these are also CPET negative. These are MRD negative, but are also CPET positive, and the outcome is completely different. So think about, in terms of myeloma, much more of a lymphoma. It's not a leukemia. We have been thinking too much in terms of a leukemia pattern. Probably the pattern is much more bind to a lymphoma model. This, of course, is the story of the continuous therapy, and the story of the continuous therapy where probably even in the good prognosis in the CR patient, you can see here after transplant or after conventional therapy, the difference is still relevant even in patients who achieve CR before starting of maintenance. And then also there are new drugs coming beside the lenalidomide that is a standard. The Ixaxomib has been just saw in the previous slide. This might represent an alternative to the IMiD, and the combination of them may represent even a further improvement. What about risk stratification? This is going again to basically the topics of my presentation today. This is an early versus late transplant study. This is randomized study. This is a progression-free survival. But I would like to show you in terms of risk. This is transplant in standard risk. This is transplant in high risk, but this is also conventional treatment in high risk. So the message is the moment you delay an effective treatment, like here, you delay autologous transplantation, you basically transform this standard risk patient in a high risk patient, and in a standard risk this would be much better. And this is basically the same story coming from another paradigm. You can see here the ASPIRE study, KRD versus RD, and you can see here that the KRD, here there is exactly the opposite. The KRD high risk are equal to RD standard risk. So once again, there is the switch in terms of prognosis. So which is the standard today for younger patients, and that's why I'm so concentrated in the newly diagnosed patient? I would say today the standard is certainly, and the free drug combination, you can consider bortezomib, IMiD, or chemotherapy. The 4 courses, probably the tandem will show to be better than the single, still in presence of the novel agent, a consolidation for another 2 to 4 courses, and the maintenance. This is probably what is considered the best possible treatment today, and in the future you can see what we are going. Certainly the novel, the presence of the second generation proteasome inhibitor Carfilzomib, and you can see here where probably represent the new way to have a free drug combination in the upfront with the increased probability of complete response and probably a better outcome. But certainly, and also this is coming from a combined effort from the French group and the Ovon group, and the introduction of the Daratumumab, the anti-CD38 monoclonal, in the combination with the standard that once again you see here, the presence of an induction, an autologous transplantation, and a consolidation. Now the other issue is what about early versus late transplant? This is still today clear. Transplant is a must up front. There is no question that there is a major advantage from this point of view, but I would also say that the curves are getting closer. The difference between the two arms are getting closer. I don't know if this is due by the introduction of the proteasome inhibitor, but I would like to show here these slides where when you compare conventional treatment with IMiD versus MEL200 and maintenance until progression, the difference is 20 months, while in this study where you use VRD and MEL200 with only 1 year of maintenance, the difference between the two arms is only 8 months. So probably once again we have cumulative evidence here that lowering the dose intensity of the continuous therapy might reduce the efficacy of those approaches. What about the elderly patient? Certainly we have today the introduction in Europe, certainly the combination bortezomib, melphalan, and prednisone is the standard. Now we have the introduction of the two-drug combination, the RD, continuous therapy versus 18 months or MPT. We just saw from ASH and the SWOG study that the combination VRD is superior to RD, both in terms of progression-free survival and overall survival. And today, honestly, this is the best available regimen in terms of efficacy, in terms of data shown in the upfront setting without autologous transplantation. We have also something coming, the Carfilzomib in combination with melphalan, but probably also the weekly infusion of Carfilzomib in something that might become a new opportunity for the conventional treatment. And the Ixaxomib, the oral counterpart of the bortezomib, intravenous and subcu, so an oral proteasome inhibitor in combination with an IMiDs and dexamethasone might represent the other opportunity, especially for the elderly, especially for the frail, especially for a home-based regimen. Now to close, for the frail patient, what is important to recognize, and this once again is a matter of cost efficacy, that the presence of comorbidity needs to lower the dose intensity of our treatment. The cutoff for the frail condition is really 80 years of age, is not 75, and we should always consider a patient fit if without major comorbidities up to the age of 80, or frail if older without comorbidities, or younger with some of those comorbidities. And here has been clearly shown by several studies that probably the two-drug combination is equal to the three-drug combination. So the paradigm for the treatment becomes autologous transplantation for the young, the three-drug combination for the fit, and the two-drug combination for the elderly frail. To close, in the salvage therapy, we do have many new combinations coming. One is certainly the ASPIRE study, the combination Carfilzomib, lenalidomide, and dexamethasone, has been shown before with 26 months of median progression-free survival. The other one is the oral proteasome inhibitor Ixaxomib with lenalidomide and dexamethasone. And has been already touched, we have several immuno-oncology agents coming, and certainly between we are starting with elotuzumab. Daratumumab is also another agent that has been recently approved in the United States, and the phase 3 study have been clearly showed the efficacy of this combination over the two-drug combination, lenalidomide and dexamethasone. Also for the daratumumab, once again, we are looking to those three-drug combination, and we will also present the combination of daratumumab and bortezomib after a phase 3 study at the next ASCO. To close it, there is a major confusion on how to use it. Certainly the cost is becoming a major concern, but for who can afford it, basically, things should be, in my opinion, suggested in this way. And we have certainly the first-line treatment, and now we are moving from basically, I would say, 4 types of treatment. One is the combination with the inclusion of the new proteasome inhibitor, Carfilzomib in the young, in the younger, and Ixaxomib eventually for the oral counterpart. So the novel in the salvage regimen, this might represent the novel proteasome inhibitor combination. Certainly we also have a combination including the monoclonal antibodies, and once again here both the elotuzumab and the daratumumab might represent a moving from the RD to the RD plus a monoclonal or VD plus monoclonal, and in the later stages the use of pomalidomide and panobinoside in subsequent relapses. So my conclusion is we have been clearly improving the outcome of our patient. I would say that it's very important to get concentrated in the newly diagnosed patient. Early intervention, CR rate, and continuous therapy are the focus. The transplant, the free drug combination, and the two drug combination do represent the standard available today, and probably in the future more and more we will see a combination including an antibody plus a proteasome inhibitor plus an IMiD plus the usual dexamethasone with or without autologous transplantation. To close it, I want to thank you, I said it before, all the many people that at the end of the day make all these things happening in the real life. Thank you very much for that.